My presentation for the next 20 minutes is ultra-low dose CTA, how low can you go? In our hospital, the installation of the Ghekiere 1 vision was in June 2013, and in the first year we performed about 1,600 cardiac CT examinations. We had also the opportunity to do the medical screening for core stability and muscle strengthening of the illotobilical professional riders on this Ghekiere 1 vision scanner. So to answer the question of my topic, I can show you this clinical case with an effective radiation dose of 0.16 millisievert. It was a 44-year-old female presenting with retrosternal chest pain, retrosternal pain, and ECG modifications at a bicycle test. The heart rate during the acquisition was 68 beats per minute, and only 36 cc of iron 500 was injected at 4 cc per second. You can see the excellent image quality of the right coronary artery and the LAD on this curved ampere view. I can show you this clinical case with an effective radiation dose of only 0.08 millisievert, less than a chest X-ray. It was a 14-year-old football player presenting with a syncope during sport practice, and CTA was performed to exclude congenital anomalies of the coronary arteries. You can see the diagnostic image quality and the normal appearance of the right coronary artery and the LAD in this curved ampere views. The heart rate during the acquisition was 51 beats per minute, and only 20 cc of iron 400 was injected at 3 cc per second in this patient. But what is more interestingly is that also more difficult patients, patients with a higher heart rate, obese patients and patients with an arrhythmia can be scanned at a low radiation dose and with their diagnostic image quality. Here you see a clinical example of a 53-year-old morbidly obese female with a body mass index of 41.4 and a heart rate of 50 beats per minute. The effective radiation dose was 1.74 millisievert. You can see the excellent image quality of the LAD and the right coronary artery in this curved ampere views. I'd like to show you also this clinical case. It was a 52-year-old female with a heart rate of 92 beats per minute. It was also an obese patient with a body mass index of 36.4 kilometers square. And you can see the excellent image quality of the right coronary artery due to the scanning at the end systole and the multi-segment reconstruction of the whole heart data acquired over 2 cardiac cycles. The effective radiation dose in this patient was 2.46 millisievert, and this becomes possible due to the technical advances of the Ghekiere 1 vision with a faster gantry rotation time of 275 milliseconds, coverage up to 16 centimeters, and the iterative reconstruction, the RD3D. Given these technical advances of the Ghekiere 1 vision, we aim to investigate if the beta blocker use is necessary to obtain diagnostic image quality at low radiation dose on CCTA examinations. So in this prospective study, we included 200 consecutive patients referred for clinical purposes and with different heart rates, and they were divided into 2 groups. We had the first group without beta blocker use, and the second group, 103 patients with beta blocker administration. The target heart rate in the second group was 75 beats per minute to do 1 heartbeat scan at the diastolic phase. Then the images were evaluated by 2 independent radiologists for motion-related image quality in all coronary segments more than or equal to 1.5 millimeters. And this using a 4-point scale from grade 1, excellent image quality, to grade 4, unavailable. Then we did multi-regression analysis of the effective radiation dose and the image quality scoring, including the following variables: the age and the body mass index of the patient, the heart rate during the acquisition, the use of beta blockers, the caliber of the coronary segment, the presence of an arrhythmia during the acquisition, the scan length, the number of heartbeats per scanner, the Agatston calcification score, the MA and KV, and the signal-to-noise ratio. These slides provide the flowchart of our study. 208 patients were referred for CCTA. Patients with calcium channel blocker and coronary bypass surgery were excluded, and the remaining 200 patients were divided into two groups. So when we look at the comparison of the patient's demographics and cardiovascular risk factors between the group without beta blocker administration and with beta blocker administration, we found no significant difference between both groups regarding the age and the body mass index of the patients, the presence of an arrhythmia during the acquisition, the scan length, the number of coronary stentings, the Agatston calcification score, the signal-to-noise ratio, and also the radiation dose. Although the heart rate tended to be higher in the group without beta blocker administration, and this may or can be regarded as a selection bias in our study, since mainly patients with a higher baseline heart rate have had a beta blocker administration. So the mean radiation dose of the 200 patients in our study was 1.47 millisievert, and this represents a reduction of up to 50% in comparison with our previous 64-slice scanner, already equipped with prospective gating and iterative reconstruction. The effective radiation dose was less than or equal to 1 millisievert in 49%, and more than 4 millisievert in 11 patients, including 6 patients with an arrhythmia, 1 morbidly obese patient, and 4 patients with a 2 heartbeat scan and overweight. Here you see a clinical example of an effective radiation dose of more than 4 millisievert. It was a 60-year-old female presenting with a coronary stenting in the LAD and arrhythmia during scanning. You can see that the acquisition was interrupted due to the presence of a ventricular extrasystole and delayed to the next heartbeat with an opening of the scan window. You can see the excellent image quality of the LAD at this curved Ampere view with a sharp kernel. You can see that there is a patent stent in the mid-LAD, but there is a moderate stenosis just above the proximal part of the stent. And you can see the correlation with the invasive coronary angiography. So for the image quality, 695 coronary segments were missing or less than 1.5 millimeters, resulting in an analysis of 2,505 coronary segments, and 99.8% were evaluated grade 1 or 2 by both readers. Only 5 segments were evaluated grade 3 or with moderate artifacts, and there was a good inter-observer agreement. Here you see a clinical example of a 55-year-old woman with a heart rate of 72 beats per minute and moderate artifacts, grade 3 artifacts at the mid portion of the right coronary artery. The effective radiation dose was 0.48 millisievert. The mean body mass index of the 200 unselected patients was 27.1 kilogram per meter square, and about 65% of the patients were overweight, obese, or morbidly obese. When we look at the heart rate during the acquisition of the 200 unselected patients, we found that almost 70% of the patients had a heart rate less than or equal to 65 beats per minute, and 10% of the patients had a heart rate of more than 75 beats per minute. More than 1 heartbeat scanner was performed in 26 patients, including 20 patients with a heart rate of more than 75 beats per minute, and 6 patients with an arrhythmia. Here you see the example of a 40-year-old man with a heart rate of 109.5 beats per minute. You can see the excellent image quality of the right coronary artery due to the scanning at the end systole and the multi-segment reconstruction, resulting in a radiation dose of only 2.70 millisievert. So we identified also the risk factors associated with the radiation dose using a linear regression analysis, and we found that nor the beta blocker use nor the heart rate had a significant impact on the radiation dose. In older patients, the presence of an arrhythmia during the acquisition, a higher body mass index and calcification score, more than one heartbeat scan and a longer scan length had a significant negative impact on the radiation dose. We also investigated the risk factors associated with the image quality using a generalized linear mixed model, and we found that a greater caliber of the coronary vessel and a higher signal-to-noise ratio had a significant positive effect on the image quality, while an older age of the patient, a higher calcification score, and a higher heart rate had a negative impact on the image quality. So we looked to determine the heart rate cutoff value for good to excellent image quality, and in patients with medium values of the variables age, caliber of the coronary vessel, calcification score, and the signal-to-noise ratio, meaning a 61-year-old patient with a Gadsden score of 75, a signal-to-noise ratio of about 22, and a coronary caliber of 2.8, the heart rate cutoff value for 90% probability for good to excellent image quality was 73 beats per minute in our study. You can see that this curve has a quadratic fit, and the probability for good to excellent image quality decreases above 80 beats per minute. So interestingly is that we found that the cutoff value for good to excellent image quality differ on the minimal or maximal values from the variables age, caliber of the coronary vessel, the Gadsden score, and the signal-to-noise ratio. So for example, when you see in this curve, the probability for the good to or excellent image quality in a 27-year-old patients, the curve seems to decrease less rapidly in comparison to a patient with an 86-year-old patient. The same can be said for the caliber of the coronary vessel. So for patients with a caliber of the coronary vessel 66 millimeters, the probability for good to excellent image quality decrease less rapidly in higher heart rates in comparison with the smaller caliber. So for pediatric cardiac CT, we all know that echocardiography remains the primary non-invasive imaging tool, but for diagnostic additional anatomic information, invasive cardiac catheterization was often required. With the installation of the Aquilion 1 Vision edition, we can obtain diagnostic image quality at very low radiation dose and a low amount of contrast medium, and it can represent a non-invasive alternative to invasive cardiac catheterization. Here you see a 4-year-old boy presenting with an anomalous origin of the right coronary artery seen at the ultrasonography, and the heart rate during the acquisition of the scanner was 76 beats per minute. The radiation, though the dose length product was only 3.7 milligram centimeters, and only 14 cc of iron 400 was injected at 2 cc per second. You can see the diagnostic image quality at this posterior 3D view and this axial MIP view of the anomalous origin of the right coronary artery from the left sinus of Valsalva, and presenting an interarterial course between the aorta and the pulmonary artery. Another clinical case, a 5-year-old boy presenting with heart murmur and with a suspicious of an aortic coarctation, So a cardiac CT scan of the heart and the thoracic aorta was performed, resulting in a scan length of 16 centimeters. And the radiation dose, the dose length product was slightly higher with 40.4 milligram centimeters. And the heart rate was 89 beats per minute during the acquisition. Also in this case, only 14 cc of iron 400 was injected at 2 cc per second. And you can see the diagnostic image quality of the patent ductus arteriosus shown between the proximal descending artery, aorta, and the pulmonary artery. So in conclusion, using a second generation 320-row CT scanner, we can obtain diagnostic image quality at very low radiation dose and reduce contrast volumes. Heart rate remains determined for the image quality, but we found other parameters in our study for the image quality, including the signal-to-noise ratio, the age of the patient, the caliber of the coronary vessel, and the Agatston calcification score. In our study, also the beta blockers used for the cardiac CT did not result in a better image quality or lower radiation dose. I also showed you that pediatric CTA becomes possible with the Achillion 1 vision at very low radiation doses. Thank you.